We are going to talk about death and dying today. And I know this isn't a fun subject, obviously, and some of you have had experience in this area and some of you have not. But we're going to talk about, as a CNA, how we're going to assist with that. So CNAs care for dying patients in many environments. Most people would prefer to die at home. If you ask most people, where would you prefer to die, they'd say they want to be at home, surrounded by their family and their loved ones. But only about 20% of the people actually get that opportunity. Over 50% of the people who die are going to die in a hospital setting. Even 1/4 of all nursing home residents that will be transferred back to a hospital in the last few days of life. So there are a lot of areas. If we're doing, as a CNA, if we're working in a hospital, we're going to be assisting in this process. If we're working in a nursing home, we'll assist in this process. If we're working in home care, we will be assisting in this process. And we're going to learn how to meet those needs of these residents or patients that we're going to be taking care of. So there are some key terms that we need to learn. End of life care. That is support given during the end of time, during the time of nearing death. Okay, so end of life care. So we're expecting them to die soon, and it's that care that we're giving them as that death process is happening. A terminal illness. Now, we talked about this back on the very first class of our school, where we learned about acute care, or that we had acute illnesses, chronic illnesses, and terminal illnesses. But a terminal illness is an illness where the person is not expected to get better. It is expected to end in death. And I'm not saying that there's not miracles out there that happen, or that there's not like, oh my gosh, this person was supposed to die and they miraculously got better. But in general, a terminal illness, we're not expecting the person to live, that they're going to die. Now, hospice care is when death is expected within 6 months. So they have that terminal illness, and we're expecting them to die probably within a 6-month window. And there's no absolute on that. The doctors don't know exactly when a person's going to die, if it's going to be weeks, if it's going to be months. But when they're thinking that they're probably in the last 6 months of life, they may order hospice care. Now, hospice care is not concerned with life-saving measures. Hospice care is going to focus on the physical, emotional, social, and spiritual needs of that person to help them die with quality and with dignity. And they're going to help that person with the emotional aspects of it and the family as well. Now, as far as hospice care versus palliative care focuses on relief of symptoms as well, but the illness can still be being treated. So palliative care and hospice care are very similar. They're going to help with the physical symptoms that the person's having, the emotional, social, and spiritual impact that the person's going through because of their illness. But with hospice, they are no longer actively seeking treatment. They are accepting of death. They're going to be a do not resuscitate. And if they die of natural causes, we're going to let them go. Where with palliative care, they still may actually be seeking treatments and cures. Now, your attitude about death, a lot of this is going to depend on your experience, if you've had any experience with death. Your culture, your religion, and your age is going to influence your attitudes about how you feel about death. Some people have never had any contact with a dying person. Some people fear death, and others are very accepting of it. So it really is going to depend on where you're coming from and where the resident's coming from. If they've been suffering a long time, they may actually look at this as a relief, okay? Where other people, and especially younger people, are feeling like they've been cheated of time. So culture and religion, we mentioned, makes a big difference. As far as age goes, if you polled most adults and you asked them, what would you be afraid of dying, they would say of fear of pain and suffering, dying in pain and suffering, and dying alone. That is probably the most common things that people will complain of being afraid of when they're going to die. And they also worry about the people that they leave behind, and they resent it. They may resent the time that they're going to be missing with those people. So, our attitudes, we said they're related to religious and spiritual needs. Some people believe in afterlife, others do not. And this is one thing that, regardless of what your religious beliefs are, when a person is dying, we cannot try to get them to see our religious beliefs. Maybe they don't have any religious beliefs, and you want them to because you know they're dying, and that is not your responsibility or your right to do that. So some believe that the body keeps its physical form. Other people believe only the spirit or the soul is present in the afterlife. Some people believe in reincarnation, that their spirit or soul is going to be reborn into another human body or another form. So there's a lot of different beliefs out there, and everybody has the right to their own belief and their own views on that. Now, Elizabeth Kubler-Ross was a psychologist, I believe, psychiatrist, or I think she's a psychologist, and she came up with what we call the stages of dying. And it's actually the stages of grief, but a lot of people now refer to it as the stages of dying. And the first stage is denial. So if somebody told you, I'm really sorry, your tests show that you're going to die, your first response is probably going to be, you made a mistake. We need to double check this. I think there's something wrong here with this. The person doesn't really quite believe that this is what's going on with them. Then stage 2 is anger. Why me? I'm a good person. I go to church. I donate in the community. Why me? Why not that person who's not very nice? So they get angry. Then comes stage 3, which is bargaining, and it's, God, if you just let me live a little bit longer so I can see my child get married, I'll be a really good person, I'll take care of things, I'll donate more, just let me live long enough to see this event. So they start bargaining for more time. And then depression. They're sad, and they mourn for the things that are going to be lost and the future loss of life, and what they're going to be missing out on, and what they're not going to get to see. And then acceptance. The person starts becoming calm and at peace with this, knowing that this is going to happen. Now the thing is nobody goes through all of those stages at one time. People jump in and out of the stages. They may go back and forth between the stages. And the other thing that's really happens here a lot is sometimes the family's going through these stages as well, and sometimes the family's in different stages than what the resident is. So that can always make it really difficult as well. So as far as psychological, social, and spiritual needs, they may need to talk, and one of the best things we can do for them is listen. Listening is so important. It's just such an incredible communication tool that we tend to forget about. We tend to think that if we're not talking, communication isn't happening, but we just need to listen sometimes. And you can ask them, would you like to talk, or you seem sad, how can I help you? The one thing you don't want to do is any pat answers, like everything's going to be okay. It's not going to be okay. You're going to a better place. You don't know where they're going. No cliches, no pat answers. If the person's upset, if the person's crying, don't try to avoid them. They need someone to talk to. And as a nurse, you're a safe person. You're a safe person. Touch shows concern and caring. And even if they don't want to talk, they may just want you to be there. And you can ask, is it just okay to sit with you for a while? You don't have to say anything. They don't have to say anything. Okay? Just that human touch. And if they want to see their spiritual leader, we will always try to arrange that for them. And if their own spiritual leader isn't available, if they want to see, they have someone call at the facilities, that we can always get somebody in to visit them. Physical needs, the dying process can be very fast or it can be very slow, but we want to give them as much dignity and respect as we can through this process. So a lot of times vision will blur and it'll actually eventually fail altogether. Speech may become harder to understand. Hearing, of course, they have found is the last sense usually to go. And so always keep that in mind, even when a person may not be responding any longer. We've talked about this with comatose patients. It's been well documented that they still may be able to hear. So always, still explain what you're doing. Be respectful, even if they're not responding anymore. Nutrition may start becoming difficult as a person's body is starting to shut down. So we can offer them small, frequent meals as tolerated instead of large meals. Oral care is something we want to do for them. It promotes comfort. So we give routine care even if they can't eat or drink, or if they can eat or drink, we're still going to make sure we give routine care. If they are unconscious or they're not eating or drinking, oral hygiene at least every 2 hours if they're not taking any fluids. So if they're not able to take fluids and eat anymore, We can still actually brush their teeth with minimal toothpaste and toothbrush. We just wipe up the excess stuff with a swab. And then every 2 hours you can take a toothette, one of those foam pads on that, looks like a popsicle stick with a foam pad, and you just swab around the mouth to moisten it. You can use some like water-based chapstick on their lips, just to kind of keep their lips and their mouth moist. Nasal care, if they're on oxygen or they have feeding tubes, they can get crusting and irritation around the nostrils. It can happen from nasal secretion, so we want to make sure that we carefully clean the nose, provide a lubricant if directed by the nurse. Skin care. So circulation tends to decrease. And believe it or not, the body's temperature can actually go up, but the skin will feel very cool. So that it'll feel really cold. They'll feel cool, like they're too cold, but their temperatures a lot of times actually go up. They may look very pale or cool, and they might look mottled. Mottled is where they look splotchy looking, kind of bluish white all over the body. So skin care is very important. They still need to make sure they're clean. We'll do frequent repositioning as needed for comfort, but just remember to turn them slowly and carefully. Back massages if there's no red areas over the bony prominence. And remember what we talked about when we talked about pressure ulcers. They can get what's called a Kennedy terminal ulcer, where when in the dying process, the last few stages of life, sometimes their skin goes from being intact to being a really deep ulceration. And it's mainly because the body's starting to shut down and they're not getting enough oxygen to those tissues. Elimination may become an issue for them. Even if they were continent before, they may start becoming incontinent, so they may need frequent perineal care. Now, we've mentioned when we've talked about urinary tubes that we do not generally put urinary tubes in just as a as a convenience method for incontinence. But if the person is incontinent and they're dying and it's bothering them, getting them turned and cleaned up so much, if they would prefer a urinary catheter, we will put one in for them if that makes them more comfortable. Yes, urinary catheters increase the risk of urinary tract infections, but if the patient's dying anyway, that's not really our concern right then, and we want to just make sure that we're making them as comfortable as possible. And urinary retention, their body may actually start holding on to the urine, so then they would also need a urinary catheter. Constipation, again, if they're not active now, and they're not active, they're not drinking much, they can get constipated, so they might need an enema or something to relieve that constipation. Plus, if they're having pain, if we give them a lot of narcotics for pain management and pain control, narcotics tend to cause constipation. So people are frequently afraid of dying. When people are dying, they're afraid that they're going to die in pain. And so pain medications are usually available, and they're usually ordered quite liberally when a patient is dying. So when I mentioned when we were talking about comfort and rest and pain management, I said that we generally, sometimes with chronic conditions, we give pain management to give them their quality of life, but we don't necessarily always worry now about taking care of every bit of pain away from them if it's a chronic ongoing issue, because we don't want them to end up with too much pain medication. But when it comes to pain medication with a dying person, it will be ordered very liberally. We want their pain management to be taken care of. Now, sometimes family members are really going to struggle with this because they don't want the person to have pain medication because they're afraid it's going to hasten death. They're afraid they're going to get addicted. Well, if they're dying, that's not going to be the issue. But they're also afraid that they're going to get too drowsy and then they won't be able to talk to them. And a lot of times the family members still have things they want to say. But we have to make sure and as a CNA, you're not going to be giving pain medication. But the nurse has to explain that, our goal is to make this person as comfortable as we possibly can, and how important that is for them. So families can make things very difficult. Okay, families can be exceptionally difficult sometimes to deal with. As I mentioned, they go through those stages of grief as well, and not always at the same pace that we do. So we need to be courteous and considerate. We're there for the resident, for that patient, but we need to help the family as well as much as we possibly can. They're grieving as well. They're struggling as well. Generally, when a person's dying, we let them stay as long as they want. I know things are a little bit different in this COVID-19 era, but as a general rule, families are allowed to stay with the patient when they're dying. They may want to help with care. They may be sad, tearful, or angry, and sometimes they lash out at nurses. And it's not because they're angry with you. It's not that you're not doing a good job. They're just angry that their loved one is dying, and they don't know how to express it. And you're a safe person to lash out to. So you have to keep that in mind and not get defensive with it and just realize what a horrible thing that they're going through. Some basic do's and don'ts when helping a grieving family. Listen more than we talk, okay? It's okay to have silence. Answer questions, or if you don't know how to answer the questions, refer them to the appropriate people. Get someone else in there who can help them. Be genuine and caring, and let them express their feelings without passing judgment. Many of these people don't grieve the way you think you would grieve or the way you think they should be grieving. Everybody grieves in a different way. Everybody grieves in a different way. Now, someone asked me before, is it okay to cry? Is it okay when the person's dying that if you're crying? I think it is. I mean, everybody may have different views on that, but I personally think that, if when a patient dies and you're crying, I don't think that's really a problem. I think, if anything, I think the family knows that they were important to you. But if you're crying and so upset that the family's trying to console you instead of you, the family, then I think there's a problem. Don't dominate the conversation. Don't ask question after question. No cliches. No, I know how you feel. They're in a better place. This is God's will. That's not helpful. It's really not helpful. Please don't pass judgment. Everybody grieves differently. Some people are very stoic. They show no emotion. Some people are just weeping and hysterical. Some people are angry. I mean, it's just, you cannot pass judgment on what they're going through. Don't avoid them because you're uncomfortable with the dying person. And don't change the subject when they want to talk about it. Sometimes they need a safe person to talk to, and that's what you're going to be for them. They may not be able to tell their family about their concerns and what's upsetting them, but they might be able to tell a nurse. So, and I don't ever feel like I have to have all the answers. If it's something I can't answer and they need an answer, I'll try to find out for them. But I think it's okay not to have all the answers, okay? But again, we can try to connect them with the appropriate people. Now, there are some legal concerns. People have the right to die without machines or other measures to keep them alive. So the Patient Self-Determination Act and OBRA give people the right to accept or refuse treatment, to make advance directives. That's a document stating what the person's wishes are about their health care when they can't make their own decision. So they can make an advance directive letting people know what their wishes are should they get into a place where they're dying and they can't make their own decisions. And they can also do a durable power of health care where they can pick a person to make decisions for them as well. If things are changing, and they'll put somebody in place of their healthcare choices if they can't do it themselves. So people have the right to accept or refuse treatment, as I mentioned. A living will is a document about measures that support or maintain life when death is likely, and it can instruct doctors not to start certain measures. Now, in the nursing homes, one of the really nice things in a nursing home is even if they have an advance directive where they've determined, what they want done, the physicians are required by law to do post orders with people in the nursing home. So post orders are the physician's order for life-sustaining treatment. And so what that is they'll go over with the resident if you die of natural causes, would you want CPR started or would you want us to just let you die? If you can't eat anymore, do you want a feeding tube? And would you want it on a trial basis or a long-term basis? Do you want dialysis? I mean, there's just all these questions that they ask, so we can kind of find out what their wishes are, and the patient actually signs it. And so this is it's an important document because, as I mentioned, I mean, some of these residents in the nursing homes, they've had full lives, and now they've had multiple disabilities going on. They can't care for themselves. Their quality of life isn't quite what they want it to be at this point for themselves, and they're accepting of death, and other people are not, and that's okay. It's not our judgment. It's not what we want. It's what they want. Now, do not resuscitate or no code orders. They're allowed to die in peace and dignity. People need to understand, even if they're a do not resuscitate, they still get cared for. All the comfort measures are there. They still get pain medication. They still get made as comfortable as they possibly can. It's not like we just stick them in a room and forget about them because they're a do not resuscitate. We're still giving them good, excellent quality care. We're trying to make everything as comfortable for them as we possibly can. But when they die, we're going to allow that to happen. And as I mentioned, whether you agree with the order or not, that's not your decision. It's not your choice. It's the family's. I thought this was cute. It says, I may come to regret this, and he's got a do not resuscitate order on his arm. By the way, that's not a legal binding thing, so you really don't probably want to do that. As far as quality of life, in nursing centers, the person has the right to privacy before and after death, to visit others in private, for confidentiality, free from abuse and mistreatment, free from restraints, to have personal possessions, safe home-like setting, and personal choice. So if they are staying in the nursing home and they are dying, that is actually part of their rights. So how do we know when death is approaching? Okay, how do we know when it's getting to that point where it looks like they're probably going to be dying soon? So they may start becoming restless and agitated. So when their body's starting to shut down, they're probably not going to be getting as much oxygen up to the brain, and they can get really restless, they can get agitated, they can get drowsy or unresponsive, they can actually be in a coma state, they might be confused or disoriented. Any of that can happen depending on how much oxygen and blood flow is getting up to the brain. They might have a change in breathing pattern. So some residents you're going to see, they have different breathing patterns that happen before dying, and sometimes they'll breathe like kind of rapid and shallow, and then it gets slower and slower, and then they have periods of apnea where they're not taking any breaths at all, and then all of a sudden they'll take breath in and they'll start breathing real fast and quick and shallow, and then it slows down and slows down and slows down, and then it looks like it stops, and it's like, oh my gosh, they just died. And then all of a sudden they go and they'll breathe again. So sometimes you're going to see different changes in the breathing pattern. Decreased socialization, and they're withdrawing from things. Decreased need for food and fluids, and loss of appetite. Loss of bowel or bladder control. Their urine starts becoming really dark because they're not taking in as much fluids. The skin will feel cool to touch. It might be mottled in color, and increased pain. So how do we know approaching death? Okay, that death is coming versus death is here. They've actually died. So signs of death, they're no longer breathing, and they have no pulse. Pupils are dilated, the eyes do not blink. The jaw may relax and the mouth may actually kind of hang open. The body may release bowel and bladder contents, and the patient no longer responds. So our patient dies, and we go get the nurse, and they confirm that death has happened, and they're going to call the doctor, and the doctor's going to call the family. We want to get the person cleaned up, because generally a lot of times if the family's not already there, the family's going to want to come in to pay their last respects, and so we want the person to be clean, especially if they've released bowel or bladder functions. So we do what we call post-mortem care. Post-mortem care is care of the body after death. So we clean the person, and we want to put them in as normal of a position as possible. Rigor mortis is where the body turns hard and rigid, and that usually sets in about 2 to 4 hours after death. So we want to get them cleaned up and positioned in a position that looks peaceful and comfortable before that rigor mortis has time to set in. So the nurse will turn off any tubes, tube feedings, IV tubes. Don't take any tubes out of the body unless you've been instructed by the nurse. If the person died under suspicious circumstances, or the person's death was not expected, they might want an autopsy where they're going to check and see what caused death. And if there is an autopsy, they usually have you leave all the tubes in. So we would get the person cleaned up, we would gather up the personal belongings for the family, and again, we remember privacy and dignity at all times. Whether they're dead or not, you don't talk disrespectfully, you treat their body respectfully. You still, if someone else is helping you, you don't just have blatant conversations over their head. You always just be very dignified and respectful at all times. So, care of the body after death. I recommend that you close the eyes. A lot of times when people die, their eyes are still open, and it kind of bothers family members sometimes because they have kind of a startled look on their face. So we can close the eyes. If the person wears dentures, it's probably a good idea to get their dentures in their mouth now before rigor mortis sets in. That way you can usually get them in easier and they'll fit in. Close the mouth. Some places will actually have you put a roll, like a towel, underneath the chin to hold the chin open, or hold the chin up until rigor mortis does set in, because otherwise if it's just kind of hanging open, they don't really want rigor mortis to start like that. It just isn't necessarily overly attractive, and it kind of bothers the families. Remove jewelry except wedding rings. We usually tape those in place so it doesn't accidentally fall off. Remove drainage containers. Remove tubes and catheters if you've been asked to by the nurse. So a urinary catheter, we can't actually remove that. You just you put a tube in where they insert the water into the balloon. You just put a syringe in there and the water comes out, and the tube will just usually slide right out. But only, like I said, only remove that tube if the nurse tells you to. So we'd wash them up, clean them up, close their eyes. If their mouth is hanging open, try to put a roll or a towel or something to kind of keep the mouth up in a normal position. Put a clean gown on them, brush their hair, and then usually we'll cover them back up with a sheet. Generally, the family's going to want to come in, so we would like to get them cleaned up beforehand and get the covers pulled up on them, so basically it looks like they're resting. We want it to just look like they just peacefully died in their sleep. After the family's done viewing the body, we put an ID tag on the toe, and we put a sheet over the person, and then we put another tag on the sheet, or it kind of looks like a shroud. We put that on, another ID tag on that sheet that's covering them, and then there's one on the great toe. Denture cup, if we didn't put the dentures in, send the dentures to the mortuary with them, because if the family is going to want an open casket, they're going to want to get those dentures back in, so it will look more natural. So I am going to tell you, dying is more than just a medical event. It is, you may be afraid to take care of that person who's dying, but it can be very rewarding. Helping someone in the last stages of their life, it's a gift that you can give them. So everyone's death is very unique. You don't be afraid to be yourself. Empathize, give attention, listen to them, show kindness, show dignity, show respect at all times for these people, and try to support the family as much as you can. I am going to tell you, sometimes it's very difficult when a person dies. You'll see family members actually arguing and disagreeing with each other. As I mentioned, everybody goes through those stages of death at different rates, and everybody, even family members, they go through them, but all at different rates. So some are in the anger phase, some are in the acceptance phase, and that upsets families sometimes too. So sometimes when a person is dying, and one family member's angry, and the other person's accepting, and another person's somewhere in between in that phase. And so sometimes the family members can be difficult with the staff, difficult with each other, or bickering or yelling at each other, and you're thinking, oh my gosh, I just can't believe a family would do that. This affects everybody differently, and please, you cannot judge people. You cannot judge people with how they do or don't handle the dying process. It's going to be different for everybody, absolutely everybody. So on that note, I think we are going to end.